I'm going to talk about mechanism of injury. And mechanism of injury, I understand some of you may have recently gone to TNCC, so the good thing is, you know, this is obviously important information because you're hearing it a couple of times, and we all know in the education world that you have to teach something several times before it really becomes stuck and a part of your practice. So mechanism of injury is critical as you approach every trauma patient, because I want you to use the concepts as you begin to sort through what exactly happened, why is this patient injured the way they are, and what could potentially also be wrong with them. So as they maybe start to complain about pain in another area, or they start to show evidence of a slow bleed somewhere, you will have that high index of suspicion that, oh my gosh, there might be some other issue, because I know that this injury can be associated with the injury that was the result of their trauma. Is that making sense? Okay, I will also tell you as much as I can. I'll filter in some of our experiences that we've had over the course of time. But like Sharon, I have been involved in the trauma system here in San Diego for 25 years. I was a brand new staff nurse in a orthopedic unit and in the surgical ICU with Dr. Virgilio that she mentioned earlier. We worked very closely with him. I was there on his multiple heart surgeries, and so I know him. I know what trauma has started like, what it has become. I have family, and I went to nursing school up in LA, and I got to see how that trauma system started in a way that was very much like the system, the very organized and well-structured system that San Diego has. But if you know anything about the system up in LA anymore, it's not the well-oiled machine that we are. You know, what the people in San Diego envisioned and took the time to lay out still exists the way they set it up. So this is an exceptional and very well recognized system around the world for being very efficient and doing a good job of trauma care. So while I'm not encouraging you to go out and get hurt, if you did, you know you would get really good care. So this is what we're going to try to achieve at the end of this 30 minutes together. We're going to talk about risk of injury. We're going to talk about the effects on society and the knowledge of that mechanism in terms of your evaluation of the patient, talking about blunt injuries and penetrating injuries, and then incidents of traumatic brain injuries, spine injuries, and different biomechanics of fractures and injury patterns. As a brief overview, again, I don't want you to walk away feeling like experts. You just have to have exposure to the concepts. So when we talk about risk factors, we talk about the connection to age, and how many of you know that for sure that sort of teenage, early 20s age frame is a very high age range for risk of traumatic injury, because there's a lot of people putting themselves in risky situations. I know over the course of time, I feel like I've become more cautious. Maybe because I realize it'll hurt more, or I feel like I've got more to lose. I don't know. There's something that goes on up there that sort of changes the way you think about things. But when you look at the patients you're seeing on your unit, I'm sure you all agree that it's that younger population that are getting injured. We also have a large number of that age range that are visitors to our community through the military, and we tend to see a lot of trauma associated with the military personnel that live here. I also know that if you have sons or brothers, that you would also be able to say that you know that that age population tends to also have the gender differences in terms of more men in that age range being injured as opposed to females. So that's where we see the breakdown in terms of gender, so that the injury rate is highest in that 15 to 24-year-old age range. The risk for males is 4.6 times higher than for females, and homicide also peaks in the males between the ages of 25 to 30, where in the unintentional death rates for females is between 15 and 19 years of age. Homicide in females is at its highest between 20 and 24, and women in their late 40s actually have the highest rate of suicide. Now, I do want to frame this for you, that some of the information on these slides is from a program that we purchased as an organization from the Trauma Nursing Society. Some of the information may be a little old statistically, so I tried to weed out actual statistical numbers. Some of these conceptual things remain the same, but as I was reviewing it, I found some interesting things that I'm going to emphasize, because I believe when it was written it was true, and now that we have seen some things cycle back, and I will bring that to your attention. And this being one of them, that homicides and suicides increase in a depressed economy. And haven't we all sort of seen more in the mass media about things like murder-suicides, and just it feels like there's more of that going on these days. Murder-suicides or just murders. And it felt like several years ago that wasn't necessarily true, and I know that stress does some crazy things to people. So I'm feeling like this has cycled back around, because this slide technically was outdated a couple of years ago. We do see the highest homicide rate amongst African Americans, and the highest suicide rate in Caucasians and Native Americans. The unintentional death rate, regardless of someone's income, is highest in Native Americans, with the unintentional injury rate being higher in the low income as opposed to the wealthiest Americans. So alcohol, we know alcohol is typically a factor in a lot of our trauma injuries, whether the person that was injured was under the influence or the person who caused the injury was under the influence, but we do know there's a distinct connection. I'm sure you can all agree to that. Geography, depending on where you are, what the unintentional injury is will be different. So that motor vehicle crashes, lightning strikes, things like different chemical exposures can be higher out in rural areas. Things like poisonings might happen more commonly in urban areas. And of course, homicide tends to be highest in the urban areas. I saw a little headline on the internet news site that I was cruising this morning, and darn it if I didn't stop to read it, and I would have that information for you. But the headline was that San Diego is sort of up there on the list of targets for terrorism. So I also believe that in terms of our military presence as well, our proximity to the border, I think you guys need to stay tuned. We have a lot of opportunities through Dr. Doucette and his connection to a lot of the terrorism and DMAT classes. They're offered free, and he tends to try to get that information out through UCSD to try to get UCSD employees abreast of that information. So take advantage of those. They're very well planned out, very well done classes. They're often free or a very nominal charge. And again, because of our risk factors, because of where we are geographically, it's good information for you to have both personally and how it could impact us here at work. Also, the exercises, the disaster exercises like the national shakeouts for practicing how to respond in an earthquake, or some of them are associated with what would we do if there was some sort of a radiologic exposure or things like that. Those are opportunities that you are invited to come and volunteer at, and again, learn what that's going to be like for us if those patients start to filter into our hospitals. We have a very highly evolved disaster preparedness program. Do you all know who Therese Reimer is? Okay, that's a name that should be familiar to you. She's in charge of our program here at UCSD. She works real closely with Dr. Doucette, and she's very involved when the county is doing these county-wide exercises. And she would be someone that would be a great resource if you wanted to get involved and bring some of that information more closely to your unit and your staff. The evacu sleds and all that kind of stuff, that is her program. So she's always looking for those tools that are going to help you take better care of patients in the event of a disaster. So, temporal variations. We know that death can happen most frequently on weekends. Saturday tends to be a peak. When you talk to any of the trauma nurses, they will tell you what Friday nights and Saturday nights are like in terms of trauma calls. We will tell you during which times of year you might see more trauma versus less trauma, or what types of trauma happen during the different times of the year. Suicide they see with less variation. There tends to be a peak on Monday, and there tends to be fewer on Fridays and Saturdays. Like, people can make it through the weekend, but once their regular routine rolls around on Monday morning, they just can't take it. And then unintentional injuries are more temporally related to recreational activities. So, surfing accidents, swimming accidents, obviously in the warmer months. Although hypothermia can happen in the colder months here, with people falling asleep in outside with our indigent population in Balboa Park, yet hypothermia in the winter months is going to be very different in say the winter and the spring in different parts of the country. We also tend to see fire injuries throughout the year. They might be different, like more of a contained fire in a home during the colder months, but people falling into fire pits and things that they were doing outside during the summer months still occur. And then we always see the ATV accidents, so people outside enjoying the desert being transported to us as a trauma center or across the border. Okay, so the initial assessment, I think that Lisa may have gone over it. Just a reminder, they're going to talk about the ABCs of trauma. They're going to look at what needs to happen in terms of life-sustaining interventions. How do they maintain this patient and get them through their initial resuscitation and the diagnostic phase to figure out what are we working with, what do we need to treat immediately, and what are we going to spend more time working up down the road and deferring to a later date after we get through the initial resuscitation. So they're going to gather some history about the event from the paramedics, as well as from anybody that may have been with the patient or the patient themselves, if they're able to give that information. All of that, you become a detective, and all of that starts to paint a picture of what happened to the patient. The thing I love about trauma, and have always loved about trauma, is that there's a lot of time and energy put into researching these trauma patients. What happened in the event? What do we know about what we saw at the scene? What did the car look like? What did the patient look like in terms of where they landed or where the paramedics found them? So all of this puzzle gets put together, and the whole trauma throughout the world learns, because all of this information is fed back into trauma systems, and they share through good research and through their aggressive publications and sharing networks so that everybody can learn. So the things that you see and that you actually go out and research and then look for in terms of purchasing a new vehicle, all of that has come from really good trauma research about accidents and injury patterns that were associated with it. Okay, so again, more history about what was going on with the patient and what caused the injury. Was it a motor vehicle crash? Was it a motor vehicle versus pedestrian, a motorcycle crash? Was it an assault or a fall, some sort of a penetrating wound like a gunshot or a shotgun or a stab wound? And then we start looking at what was the mechanism, how did the injury occur, what was the type of the force, and what was the subsequent tissue response. Okay, so we're looking at not just now what happened, but understanding how did it happen. Force, we know, will deform the tissue, and based on the amount of force and what tissue is being affected, that tissue can fail, and then you can have an injury as a result. We will try to explain the type of injury, and then we will look at predicting the eventual outcome associated with that mechanism of injury, and what are the common patterns that occur. So we talk about velocity of collision with the tissue. And I'll get more into that, but there is velocity associated with a lot of the injuries we see. And then based on the type of velocity, what do we think happened? What was the object shape that was involved? What was the tissue rigidity of the tissue that was affected by that velocity? What type of tissue was it? Is it tensile, or was it elastic? Was it rigid or not rigid? And then we talk about force, and that's the mass that's moving times the acceleration of the movement. Okay? Think about, common sense wise, the individual involved in the accident versus what is causing the accident. When we talk about a motor vehicle and a pedestrian, a taller pedestrian is going to have their injury with a sedan or maybe a small car like a Mini, maybe lower in their person as opposed to a child where the force of the trauma might be higher up and closer to vital organs. Okay, a slow moving car, like somebody that was parked and was backing out slowly and didn't see somebody and clipped them on the leg, is going to be very different than somebody that was trying to speed through a light as it was turning red and there was somebody in a crosswalk. Okay, a petite elderly patient versus a bigger, stronger man with a lot more body mass that could absorb that trauma very differently. Okay. And then when we talk about forces applied, we talk about the actual motion. So we talk about acceleration, and that is not only the vehicle accelerating, but we talk about the body accelerating. So let's say the person is moving forward and their body comes to a stop against an object, but the top part of the body keeps moving. So like the head is still moving, yet the spinal cord has sort of been stopped by a larger object. Okay, that could be an acceleration injury. The deceleration injury is the sudden stop. Okay, so a patient falling. Okay, that can be a deceleration. We talk about shearing. We talk about things continuing to move after a stop. Okay, so what is happening with the tissue as it's sliding forward? Okay, we talk about compressive. So did something fall and then something fall on top of it? So a car on top of a patient, or some of these construction accidents where a lot of debris or construction material falls on a patient, or strain. So is something being pulled in one area or another? Okay, when we talk about acceleration and deceleration, it's a hard concept because you talk about the external factors, but you also have to think about the body also accelerating and decelerating. We'll talk about that a little bit more. So we talk about the, let me go back to that. When we talk about acceleration and deceleration, I want you to imagine that the car in a motor vehicle accident is accelerating forward, okay? And if it's going to hit a stationary object, there's going to be force associated with that has to be dispersed. So the stationary object, the post or the tree that the car bumps into is maybe going to absorb some of it, but a lot of it is going to be dispensed within the movement of the car and within the body, because the body is also moving forward with the car and it comes to a sudden stop. Well, what happens is the body continues to move forward, right? So the car has stopped, but then the body has to stop, but it's moving forward at least for a very brief period of time. In that situation, what stops the body from moving? A couple of things. Your seatbelt is one. Steering wheel or airbag, exactly. The windshield, right. So that's why it's important to know if the patient had a seatbelt on or not. Now, in that situation, if the patient doesn't have a seatbelt on and ends up on the side of the road, what often is the outcome? They don't make it, right? Because they are accelerating with extreme force forward, and all of that force is absorbed as they decelerate rapidly, probably onto the ground, or maybe even against another tree or something like that. So it's an extreme amount of force that is absorbed by all of the organs, okay? Now, if the seatbelt or the airbag stops the patient, that's the outside of their body. Guess what's happening inside? The tissues are still moving, and that's where you get, again, absorbing of that force, and you get some of that shearing as the organs move forward and then bounce back, right? They're being sort of stretched and pulled against the things that are holding them in place. They're hitting the inside of the chest wall or the inside of the skull. So you have to think about what is that doing, again, the associated injuries. So if it's enough force to cause them to lose consciousness as their head hits the inside of the windshield, not only is there bruising and movement of the brain inside the skull, but what do you think is happening as that force is moving down the base of the skull and into the spinal cord, and what happened to the rest of their body as they were flying through the inside of the car, okay? So that's acceleration and deceleration. So blunt trauma is typically a combination of forces. Okay, so it's forces that don't necessarily penetrate, but it's being absorbed within that space. So the force of the patient stopping suddenly, where is the impact, and then what force was basically spread, and how far did it spread based on how much force was applied to that area. These are often more life-threatening because they're so substantial and they share the wealth. All the organs in the vicinity have some sort of impact in one way or another. The injuries tend to be less obvious, but they can be extremely significant. Diagnosis can also be complicated because you don't really know where to focus, which is, again, why hearing what was visible at the scene and what people know about the mechanism of injury is so important. Okay, we talk about tissues and organs having explosive injury, so that might be the air-filled. So with a lot of force, there might be like a balloon popping in your lungs, right, with a pneumothorax. And then there's those that are fluid-filled, or solid. So you could have cracking and lacerations associated to the liver. You can have injuries of the spleen, have injuries to the pancreas, right? Okay. Blunt trauma with motor vehicle crashes, it's about 50% of the time it's a blunt injury. You also get blunt trauma with falls and assaults, and often with contact sports. Okay, so here we talk about, again, the motor vehicle crash, where you want to get that detailed history and then try to get the picture in your mind about what the impacts are. So first the vehicle is hitting an object and there is force applied there. Then the body could hit the interior of the vehicle in one way, shape, or form, whether that's because of an active restraint or because they were not restrained and they were sort of flying throughout. And then organs will then hit the bony structures of the body as they continue to move forward and then rapidly decelerate. I heard once say something about, you might be restrained, but think about the things that you have free and unrestrained in your vehicle. Okay, so I might have everybody that I'm taking in my car restrained, but we have cell phones, sometimes we have sports equipment, we have all kinds of things moving around in our car that, depending on how rapidly you're moving, they could be launched and hit you upside the head when you didn't plan it. And I actually worked with a person temporarily who was a little bit odd to begin with, and then he never came back, and his boss ended up finishing the project I was working on with him. And what he was saying was that this is the excuse he gave me, he was in a motor vehicle accident at a pretty high rate of speed, and wouldn't you know, his bowling ball got launched as he was decelerating and hit him in the head because of the force of the trauma. Like I said, he was sort of an odd bird to begin with, and that didn't help. But I think about our dogs, things like that could potentially become missiles in our vehicles if we're in a motor vehicle accident. So I'm not very good about it, but every now and again I try to clean the things out of my car that could take flight. So we talk about fractures. Fractures can accompany injuries from either low velocity injuries or high velocity injuries. There can be indirect trauma from something that applies traction to a bone or sort of torques it at a funny angle, and it can give under that pressure. Certainly it can crack under compression or a combination of any or all of those types of force. With abdominal injuries, I'm just giving you the brief overview because you're going to have some specific information when we have this lecture, but again, they're associated in 50% of the motor vehicle crashes. Liver, spleens, and kidneys are common organs to have injury when you have that force applied to the area of the abdomen. If it's a lateral impact, think about your anatomy. You're potentially affecting a kidney, spleen, or a liver, depending on what side the impact is on. Visceral injuries can be from crushing and shearing or burst fractures. When you have a crush injury, remember you've got those anterior and posterior forces applied, and a solid organ can give under that kind of pressure and will give under that pressure. When we have shearing injuries, again with acceleration and deceleration, so remember, these organs suspended in your abdominal cavity, pulling and twisting and torquing on the ligaments that suspend them and causing injuries that way. And then hollow organs can burst. Restraint devices, I think we've talked about a lot. One of the important things for all of us and for our patients is, was the restraint applied properly? And we all know laws change because of what we've learned, and those of us that have a child that's not quite 8, but last year didn't have to be in a booster seat, and now for another couple months has to go back in a booster seat because the law changed. It's because we know that it's safer. And I was having to talk to some of my daughter's parents that are frustrated, like, now we got to get the booster seat back out, or I've got to go rebuy one. And I said, it's not for any other reason than when you lift the kid up off of the seat, you can see that the seatbelt hits all the right places better. And it's for their safety. It's not to make your life inconvenient, but the last thing you want is for your child to have an injury. And I know there's people, I've heard about them on the news, that have devastating injuries to their child for a restraint that was not applied appropriately. And then we talk about passive restraints. Things like airbag technology has all come from research associated with trauma. There's been multiple billion-dollar grants that have been paid for the research of vehicles after accidents, and some of it was done here in San Diego. As a result of lawsuits, some of this money was paid so that this research could happen. And cars were taken to areas where they were stored and evaluated, and all the information about what ultimate injuries the patient had was compared to what was visible in terms of what's the word I'm looking for? Oh God, I'm drawing a blank. Sorry, you guys. So where was the actual impact? What was compromised in terms of the area where the driver is sitting? What was broken? What was crushed? So that they could compare if 50% of the time when the injury was sort of corner to corner on the vehicles, these were the common injuries in the driver, or when the steering wheel got bent, these were the common injuries of the driver. That's how things like airbags, side curtain airbags, door airbags, passenger airbags, all of that stuff has come into play. Things like crumple zones on newer vehicles are all a result of all this good research. Penetrating trauma, this is obviously when objects are passing through tissues. So we're looking at whether it's going through the organ or not. How many times do you hear that somebody got lucky and their heart was barely missed, or their lung was barely missed, and that's because somebody just the aim was wrong, or somebody moved the right way and you missed the organ, and that would be far better than actually going through the organ. We need to know the characteristics of the weapon that was used. Was it a large knife? Was it a serrated knife? Was it really long or really small, in terms of understanding the potential for the impact and the devastation to the organs that it touches? Was energy dissipated when it happened? So did the penetrating injury happen as the patient was falling, or was it an intentional injury? So unintentional can have blunt trauma associated with penetrating trauma, and you can guess that there could be the potential for more associated injuries than just the area where the penetration happened. What were the tissue characteristics of what was penetrated, and then what was the distance? So was somebody firing a gun, or were they from across the street? Was it something that it was intended for somebody else and the other person got in the way, or was it at close range because that person intended to shoot that victim? So we talk about if the skin itself is penetrated, and only the skin, the velocity is about 150 feet per second, but for that bullet to penetrate through bone, it has to be a velocity of 195 feet per second. There's a lot of research, again, that goes through what guns can produce what velocity and what particular ammunition can do what damage. So based on what the injury is and what weapon was used, we will know more about what to expect for injuries. We talk about the kinetic energy transformation. So what kinetic energy is being shared with the surrounding tissues or the organ that it passes through? Is there cavitation involved as the organ is being penetrated? We talk about outside the missile path, again, things that are disseminated as it's going through. It can be causing damage in the area of the missile, not just at the actual entry point. And how many of you have seen a patient, let's say, that has a shotgun blast? What do you know about those injuries? They're extensive. Sometimes, depending on the weapon, if it's a particular kind of ammunition, we might see the worst injury on the exit site as opposed to the entry site. So again, all of this stuff is very well studied, and that information is very well known. And then the velocity is going to determine the amount of cavitation and the amount of tissue deformity that's associated with it. So I don't think we need to go into a lot of gunshot wound information. Inhalation injuries we do see here. Some of these are automatically determined to be treated by the burn team, so we may not see them in our units, but there are times that we will. Most immediately, we want to look at the exposure to carbon monoxide as a potential for harm to the general population. And then when we talk about inhalation injuries, we're looking at those that are potentially exposed to smoke or some sort of maybe a toxic gas or a chemical exposure. And we're definitely concerned about the oropharynx, the nasopharynx, and then all of the trachea and the lungs. So lastly, I just want to remind you that we are at risk. We should all be considered at risk for acts of terrorism. We know that that is a medical and a health issue. If you haven't, I know that some of you don't necessarily have time when you're at work to go just sort of peruse the intranet, but our disaster preparedness site on our intranet is very well done. There's a lot of really good information on there. So again, I encourage you to avail yourself of some of the education and volunteer opportunities I'll ask to make sure that Sharon shares that with your managers so she can get it out to you, to any staff that are interested. But I do encourage you to look through the disaster preparedness site, because if you're at all interested, there's really good information about what the different agents are and what we might need to know in terms of, again, our own personal safety and what would be expected of us if we needed to come in and deal with patients here in the hospital in those situations.